Hello, my name is Gustavo Lucar, and I'm going to talk about our experience in Walant technique in foot and ankle surgery. So, what is possible in foot and ankle surgery? We can do general anesthesia, we can do an intradural injection, we can do ultrasound guided proximal block, or even local anesthesia. This is Mater Hospital nearby Barcelona. When me and Dr. Ballester perform about 304 foot surgery, ankle surgery, and hind foot surgery cases each year. What we used to do in forefoot surgery was popliteal block plus tourniquet. And for most of our ankle and hind foot surgery, we used to use the intradural anesthesia plus tourniquet. This carries with a longer period and postoperative preparation, the need for anesthesiologist, heparin, and the use of tourniquet. We know for sure that tourniquet can cause nerve damage, wound pressures, pain, psoriatic pain, and also rhabdomyolysis. So we used to use the local anesthesia basically for small cyst and lesser surgery. So how do we do our Walant surgery? First, at the preoperative environment, we administer 1 milligram of midazolam, 0.1 cc's of adrenaline, 5 cc's of lidocaine at 2%, 5 cc's of saline solution, and 2 cc's of sodium bicarbonate. If we want to do more surgeries, what we can do is prepare a bigger bag of 1 cc's of adrenaline, 5 plus 5 cc's of lidocaine at 2%, 20 cc's of saline solution, and 10 cc's of sodium bicarbonate. It's well known that the toxic limit is about 7 milligrams per kilogram. That's basically 5 times our cocktail for one surgery. This may sound like cocktail preparation or even alchemia. And trust me, we are orthopedic surgeons, so that can cause a little of confusion. In that case, what we did was talk to the pharmaceutical department when they did preloaded syringe for these kind of surgeries. Basically, they prepare a 10 cc's syringe for aching whale Morton's neuroma. And if we want to do bigger surgeries, basically we use more than one. Normally for bigger surgeries such as whale, MTF fusion, or even M1 osteotomies, we use about 20 cc's. And if we need more anesthesia, what we should do is use more saline solution to expand it. So how do we do it? In forefoot surgery, we start doing like a Mayo block 30 minutes earlier, starting medial dorsal, then plantar from the TMT joint, then going forward until the MTP and the first phalanx. Then we go to the first interdigital space, trying to reach the deep peroneal nerve. We go to the posterior tibialis nerve, superficial peroneal nerve, and if we need a digital block, we perform it in the same moment. Here is a quick view of the infiltration, starting medial, then going to the first joint, then we go to the first interdigital space, the superficial peroneal nerve, and then the posterior tibialis nerve. For the post-op protocol, We try to do immediate weight bearing. We do wound dressing change in 1 week, and we see the patients in the clinic at the third week. For Achilles rupture, what we do, we start doing an infiltration in the side of the rupture, then going 10 centimeters proximal and distal, and 2 or 3 finger breadths medial and lateral, trying to reach all the area that we're going to work. For a fibular fracture, what we do, we start doing a hematoma block. We can check it in the x-rays, then going to the incision 10 centimeters proximal and distal. Then we go to the anterior compartment and also the lateral compartment. We should wait about 13 minutes and then we start operating. We check for the correct movement of fingers and ankle with our surgery. And we have to be aware to talk to the patient. The patient must know everything that's going to happen, all the sound that we're about to make, and even the sensation that we're causing them. To start, it's important to use a small needle. Then we can use bigger needles to avoid pain in the infiltration time. It's important to avoid the dermis going subcutaneously. And also, we should follow the white road, meaning the ischemia zone, it's well anesthetized. It's important to talk a lot. It's important to talk to the patient to explain before, during, and after the surgery. Avoid noisy ORs, have a quiet environment, and it's important to also be patient. Since we use adrenaline, it's important to have red flags that could be the prolonged paleness, discomfort, or even palpitations. If we have a prolonged ischemia, we could use phentolamine to revert the ischemia from the adrenaline. The local anesthetic red flags should be metallic taste, blurry vision, and tinnitus. In this case, we should call for help to anesthesiologist or reanimation, and we can start giving intralipid to revert the local anesthetic. What are the pros of this kind of surgery? Basically, we can do faster pathways. We can do up to 5 surgeries in a single morning. We can check for tendon function. We can see our reparation, it's well done and it doesn't break. It is a cheap technique. It's easy, but we should be quite patient, and it can be carried in an outpatient surgery circuit. The weak points of this kind of technique is, as surgeons, we have more job to do. We should and we have to be with more attention to the whole environment, not just the surgery. It's not an extended technique for the moment and can cause burnout in the beginning. We should be aware and we have to know that not all cases are ideal. So for starting surgeons, we should select proper patients. There is plenty of evidence in hand surgery. In foot and ankle surgery, not so much for the moment. We hopefully have our experience in published soon. And in time, maybe we can go from the Walant classical cocktail to a new or meta-Walant cocktail, but it's up to time and only time will tell. Thank you for your attention, and I'll be more than happy to give you all the answers to your questions.